So today we'll continue our discussion about meningitis. We had chronic meningitis left. Now, as we saw in acute lymphocytic meningitis, which is caused by viral infections, or acute bacterial meningitis, which is caused by obviously bacteria. यहाँ पर there is inflammation of meninges, which will cause severe damage to your brain and so on and so forth. All the symptoms will occur where the patient is becoming nauseous, they are having vomiting, they'll vertical, they'll have a very stiff neck, especially in case of acute bacterial infection. It's technically a medical emergency where you need to treat very very quickly or the patient might go into coma and die. Now chronic meningitis is something that goes over obviously over a long period of time. It can be because of bacteria, specifically tuberculous bacteria. Okay, uh, if it is tuberculosis that is happening and chronic meningitis occurs, or it can be fungal. So fungi are causing the bacteria. All right, so in this case there are two main organisms that are causing chronic meningitis. The first one is bacteria, which is tuberculosis. Okay, the second one is fungus, cryptococcus, neoformans. Now both of these what do you call type of pathogens, they will cause a granulomatous reaction where there is granulomatous tissue coming into picture because of chronic inflammation. All right, and ultimately they will also produce parenchymal lesions where it is extending into the brain tissue, into the cerebrum, and it is causing problems there. Okay, यहाँ पर in chronic meningitis technically it should only be restricted to the meninges, but यहाँ पर क्या हो रहा, because of chronic meningitis, because it is going on for such a long period of time, it will start affecting the cerebrum as well. Now if you look at the pathology of tuberculous meningitis, what you will see is that the subarachnoid space, the vertical in the meninges, the subarachnoid space, which is directly under the arachnoid meninge, arachnoid matter specifically, it will contain a very thick exudate. Now the main primary difference between fungal chronic meningitis and bacterial chronic meningitis will be exudate itself, the volume of exudate specifically. So in tuberculous meningitis there will be a very thick abundant exudate, so there is a lot of exudate that is being produced, a lot of edematous fluid that is coming into picture, and your CSF will get flooded in a sense, and it will be specifically abundant in the case of in sulci, so in the sulci of a brain, that location, and base of the brain, near your brain stem. Okay, these two locations tend to contain a lot of this fluid. Now, in tuberculous meningitis, as it is occurring because of tuberculosis, so the patient already has tuberculosis and the bacteria. Technically, this is a form of, you can take it can be primary, but mostly it is secondary, in the sense that the patient is having tuberculosis. Let's suppose it is secondary, which is more common. The patient has tuberculosis, it is affecting their lungs, it is forming gonfocus, rank complex, gon complex, all of that is happening. There is caseating necrosis there, and from there tubercles are spreading, right? The bacteria are spreading all over your body, all of the patient's body, and ultimately they are reaching the brain as well. That is secondary tuberculosis. So the patient will also have lung manifestations along with miliary TB. So they will have millet-like lesions all over their body. One such place will be your brain, specifically the blood vessels. So the blood vessels in your brain, they will get affected by or they will be the first point of contact of your tuberculosis, because obviously it is entering your blood and flowing around in your body. You will see small lesions near your blood vessels, which will ultimately spread into your cerebrum as well in the patient with chronic meningitis. This is secondary. Primary occurs very very rarely. Primary का मतलब ये है, the bacteria is coming inside the body, but rather than first infecting or first damaging your lungs, it is entering the blood and it is going to your brain and causing brain damage first. Okay, that will be primary. So whichever damage appears first, that will be primary. वहाँ से it is mainly, let's suppose it is making its headquarters somewhere in, I'm using a very loose term, but headquarters in the brain, and from there it is operating or it is spreading other places. or it can be, which is much less common. The more common way will be secondary, wherein it is occurring as a lung infection, then spreading to other places. Now, in tuberculous meningitis, the exudate that will be present, that will have a lot of acute and chronic inflammatory cells. You will also see a lot of granulomas present in that region. Sometimes you might even see caseating necrosis. It might be both the cases, where there is caseating necrosis or without caseating necrosis. Alright, caseating necrosis being the characteristic feature of tuberculosis, cheese-like necrosis that occurs. So if we write a little about tuberculous meningitis, um, thick exudate, quite a lot actually, uh, specifically abundant in sulci of the brain, and it is present in base of the brain. All right, quite a lot. You will also see tubercles. Now these tubercles generally range in between 1 to 2 mm. Okay, tubercles around 1 to 2 mm in diameter. They will be visible near, uh, visible near, or technically adjacent to, beside, that is adjacent to blood vessels, the blood vessels of your brain. All right, so that is tuberculous necro, and you will also see sometimes necrosis occurring in that area, specifically caseating necrosis. When there is caseating necrosis, you will see giant cells entering that area. Now, coming to cryptococcal meningitis, this is caused by obviously Cryptococcus neoformans, okay, a type of fungus. Now, the specific feature about this is the exudate that is present is very scanty. There is very, very little amount of exudate altogether. And generally, the exudate will be translucent and gelatinous. Okay? Whereas in tuberculous meningitis, the exudate is thick, all right, and it is quite abundant. There's a lot of exudate. In fungal chronic meningitis, it is quite the opposite. It will be very low in volume, scanty, and it will be translucent and gelatinous. All right. You will also see a lot of lymphocytes, plasma cells present inside that, what you call, in the area where cryptococcal meningitis is occurring, along with a lot of cryptococci in themselves. So you will see a lot of encapsulated cryptococci present in that inflamed meninge. All right. So cryptococcus ka specific feature is that um, exudate is scanty, it is translucent and gelatinous. Okay. Then it is obviously invaded, the area is invaded by lymphocytes and all, and you will see capsulated cryptococcus or cryptococci near the inflamed meninge. Okay, meninges whichever are getting inflamed. Right. So that is characteristic feature of your cryptococcal infection. Now with this we have completed our meningitis. We'll jump into hydrocephalus. What is hydrocephalus and the details of hydrocephalus? Hope you understood what is meningitis and what is chronic meningitis. There is acute, there is acute bacterial, acute lymphocytic, and chronic meningitis. One is caused by bacteria, which is an acute reaction. The other is by viruses, not as acute, and technically it is a self-limiting disease, gets cured within 7 to 10 days. All right. Then there is chronic meningitis, which goes on for a very long time, generally due to bacteria and fungi. All right. Now coming to hydrocephalus. Specifically, hydrocephalus itself refers to a term where there is increased volume of CSF, okay, in your skull. So inside the brain, there is a lot of CSF being built up, which is causing dilation of your ventricles. That is the specific definition of hydrocephalus, if you may. Now, this refers to increased volume of CSF within skull, plus dilation of ventricles. All right, both of them occur together. Now, in most of the cases, what you will see, or most of the cases of hydrocephalus, you will see that ICP is sharply increasing. Intracranial pressure increases. Not in all cases, but most of the cases, intracranial pressure significantly increases and will start putting pressure on the structures of your brain. So, cerebrum, basal ganglia, all of them will start getting affected. Now, there are two types of hydrocephalus specifically. There is an internal hydrocephalus and there is external hydrocephalus. Right? Internal will be that hydrocephalus where there is ventricular dilation. Now, if you take inside your brain, let's suppose, this is your brain, okay, and this is the spinal cord which is continuing out of here. Now, if you see the continuation here, you'll be able to see that your ventricles are present something like this. Okay, one second, we draw it a little better. You have your aqueduct of Sylvius. Okay. Near these ventricles are your basal ganglia and so on. Okay. Again, please excuse my diagrammatic skills, but anyway, these will be your, you'll have two of these, so there'll be two lateral ventricles like this, okay, side by side, and think of them as someone holding a ball. Okay, it'll look like that. Basically, it is an empty space where CSF can flow through. Now, whenever there is what you call internal hydrocephalus, it will involve ventricular dilation. The cells in your ventricles will undergo dilation, and because of the pressure, the ventricles itself will dilate. Okay, or it can be localized collection of CSF in the subarachnoid space. So subarachnoid space will be outside here. Now, obviously, there is continuation where near your close to your fourth ventricle and lower near your brainstem area, CSF will meet. In the sense that the meninges will be able to flow through, the CSF in the meninges will be able to flow into the CSF coming to the ventricles. But in any case, यहाँ पर क्या हो रहा है in external hydrocephalus? So let's suppose that is your pia mater. Let's suppose this is your pia mater. Supposed to be a little more close, but let's suppose this is your pia mater and this is your arachnoid mater. Okay. If there is increased CSF present in the subarachnoid space, so in this area, right in this area, if there is a lot of CSF being built up, that will be called external hydrocephalus, technically occurring out of your cerebrum. Okay, if it is occurring inside your cerebrum, inside the cortex, in the ventricles, that will be internal hydrocephalus. If it is present in your subarachnoid space, it will be called external hydrocephalus. All right. Now, hydrocephalus can be classified based on etiopathogenesis into primary and secondary type. Okay, primary being much more common. All right. Now, coming to primary hydrocephalus, this literally an increase in volume of CSF. Okay, this is literally defined as the increase in volume of CSF, wherein there is elevated intracranial pressure. Now, this increase in CSF can occur due to three common reasons. All right. So those three common reasons. This is inside primary hydrocephalus. Okay, primary hydrocephalus occurs due to three main reasons. The first reason is obstruction in flow. This is the most common one. Obstruction in flow of CSF. Okay. Simply there is a blockage in the flow of CSF causing increased amount of pressure in your ventricles as well as in your skull, increasing intracranial pressure and increasing fluid volume. All right. Normally your CSF should be able to flow freely. It will be produced and it will be reabsorbed back inside. ठीक है, यहाँ पर क्या हो रहा, there is an obstruction in the flow of CSF because of which it is getting built up in a certain area, or it can be overproduction of CSF. ठीक है, your chorionic plexus and those cells which are involved in the production of CSF. Then there is deficient reabsorption of CSF. All right. So these three are the main reasons for hydrocephalus, but the majority of the cases you will have obstruction in flow of CSF being the main cause of what we call primary hydrocephalus. All right. primary obstruction and flow itself can be again divided into two types. They can be non-communicating and communicating. So hydrocephalus itself, based on the causative agent, it can be into primary and secondary hydrocephalus, two types. Primary is mainly caused due to three main causes: obstruction, overproduction, or deficient reabsorption. In any case, CSF volume is increasing. In the last two, in the first one, there is blockage in the flow. The most common one is the blockage in flow. Take the first one. Now, obstructive hydrocephalus itself can be divided into two types based on where the obstruction is occurring. Okay, there will be non-communicating hydrocephalus and communicating hydrocephalus. So there is non-communicating hydrocephalus. Now, non-communicating hydrocephalus is when the site of obstruction, wherever the obstruction is occurring, is in the third ventricle. Okay, so you have the two ventricles, then you have third ventricle, then you have fourth ventricle near your foramina. Okay, near your foramen magnum, uske niche se it will continue into your brainstem. All right, half of it will be present in the brainstem, half of it will be present in the skull. If you remember the anatomy of your ventricles, I'd suggest that you go and look over how the ventricles look and how they are placed. Okay, so you'll have a better idea of where to place this obstruction and where things are occurring. Now, such as I was telling you, the site of obstruction for CSF pathway is the third ventricle, or it can be the exit of the foramina, very close to that exit of foramina in the fourth ventricle. In either cases, what will happen is your ventricular system will enlarge and CSF will not be able to pass into subarachnoid space. So this foramina that is present, अगर थर्ड वेंट्रिकल के पास लिए या फोर्थ वेंट्रिकल के पास लिए, technically speaking, at the base of your fourth ventricle, near your fourth ventricle, you will have a foramina present in the posterior position. That foramina is basically a hole. That foramina is helping in flow of CSF into and out of, basically it is connecting your subarachnoid space and your ventricle. ठीक है, यहाँ पर प्रॉब्लम क्या होता, because there is blockage either in the third ventricle or in the fourth ventricle near the foramina, this passage will not be able to, this passage of CSF will not occur, meaning what you call CSF will start accumulating near your this thing, near your ventricles, and the pressure inside your ventricles will increase. This is termed as non-communicating type of hydrocephalus, where there is no communication between your third ventricle or fourth ventricle and the vertical subarachnoid space. Now, this can be either congenital or acquired over time. Depending on the cause, it will be, you know, congenital non-communicating hydrocephalus or acquired non-communicating hydrocephalus. So, obstruction is obstruction of CSF is in third ventricle or at exit of or at exit foramina, specifically in the fourth ventricle. Okay, either of these cases. Now, then there is communicating type of hydrocephalus. All right, communicating type of hydrocephalus is when the obstruction is obstruction to the CSF flow is occurring in the subarachnoid space. This is not affecting the ventricles as such, meaning it is not occurring in the ventricle or the passage of ventricle into subarachnoid space, but the obstruction itself is occurring in the subarachnoid space, specifically around the base of your brain. All right, this will also cause enlargement in the ventricular system, but there is free flow in the dilated ventricles and spinal cord. So spinal cord से ventricles में जाना easy रहता, that is not a problem. यहाँ पर non-communicating type of hydrocephalus में the connection between your CSF and your ventricles will get affected because of the obstruction, because of which communication will not be formed, or communication will be obstructed in non-communicating type. In communicating type, there is no problem in the flow of CSF between your ventricles and your spine, but the problem is in your subarachnoid space, wherein an obstruction is occurring in the subarachnoid space, not letting that what you call CSF flow into the ventricular system, or technically speaking not letting CSF flow out of ventricular system, drain into your subarachnoid space. All right, your CSF is constantly getting produced and it is getting constantly reabsorbed. If reabsorption gets blocked and production is not stopped, it will ultimately lead to increase in the total volume of CSF, causing dilation in your ventricular system. Okay, the main two reasons again for communicating hydrocephalus will be either overproduction or it is deficient reabsorption. In either of the cases, there is no problem between the flow of CSF in spinal cord and what do you call the ventricles, or technically the lateral ventricles, but there is a problem in the subarachnoid space. So obstruction, second. Flow of CSF at subarachnoid space, there is free movement of CSF in between ventricles and spine, right, or spinal cord, either way. Then there is secondary hydrocephalus. Now, secondary hydrocephalus is much more less common. Okay, it will not occur commonly, very rare condition as such, and it is defined by compensatory increase in CSF fluid. This is specifically compensatory increase in CSF fluid. Okay, यहाँ पर ये CSF fluid का compensation इसलिए हो रहा क्योंकि there is neural tissue damage. So the patient might have some other condition which is causing increase in CSF as a result of that. Matlab, let's suppose a patient has an infarction, stroke, or the patient has cerebral atrophy. Okay, there are several diseases that will lead to cerebral atrophy, basically wasting of your neural tissue. In either cases, that is the primary condition, and hydrocephalus is the result of that primary condition. Okay, hydrocephalus is occurring in compensation for that neural tissue damage. All right, so that will be secondary hydrocephalus. I hope you understood what is hydrocephalus. That will complete our hydrocephalus. Not a lot for you in your topic, in your portion about hydrocephalus. Only two main types, primary and secondary. Primary in turn can be because of obstruction or overproduction or deficient reabsorption. The last two will mainly occur in communicating type of hydrocephalus, wherein there is no problem in the flow of CSF in between your ventricles and your spine. In the first one, there is a problem. There is either an obstruction in the third ventricle or at the exit foramina in the fourth ventricle, not letting CSF flow freely. Okay, that will cause enlargement of your ventricular system. Technically, in both of them, there will be enlargement of your ventricular system, but passage is slightly different. All right, the secondary type will be literally because of a secondary condition. So the patient already has a primary problem. They have infarction or they have cerebral atrophy, which is causing neural wasting. Neurons are getting damaged and there is neural wasting, cerebrum gets damaged. Because of that, as a compensation, your body starts producing more amount of CSF. All right, so those are your primary and secondary hydrocephalus. Now coming to the next topic, encephalitis. We'll do bacterial encephalitis, then we'll continue with viral tomorrow. All right, we have encephalitis. Now, encephalitis is a condition in which there is infection of the parenchyma of your brain. So it will occur both in your glial cells as well as your neuronal cells. The whole tissue of your cerebrum is getting affected, specifically your cerebral cortex. That is the one that will get affected, and there is proper infection of that what you call cortex. This can be because of bacteria, virus, fungi, or protozoa, but the more common types are bacteria and viral. Okay, bacterial and viral. Specifically, viral will have a lot of complication, and most of viral encephalitis are very hard to treat, or they will not have proper treatment altogether. The patient will simply die within a few. The prognosis is very bad in case of viral encephalitis, especially advanced cases of viral encephalitis. Bacterial encephalitis will be, somewhat salvageable, not as bad. Now coming to the first type, so we'll just write the definition. This is infection of parenchyma of brain. Okay, the neuronal tissue and glial tissue. so neuroglia as well as neurons, both of them. यहाँ पर the first type will be bacterial encephalitis. Okay. Now, bacterial encephalitis is usually due to a secondary condition. It can be primary as well. Primary will be in case of tuberculosis or neurocephalus. Syphilis is basically a what do you call condition in which the patient will have, how should I put it? It will be a, आप लोगों को syphilis था क्या इससे पहले कभी पढ़ा है? Because it's a very big thing to just summarize like that. Have you ever been taught about syphilis? Patient will have maculopapular lesions. There'll be damage to the blood vessels and overall damage occurring all over the body depending on systems. There'll be damage to your kidney, there'll be damage to your neurosyphilis is not common nowadays as much, but neurosyphilis occurs in AIDS patient. One of the big problems or complications in AIDS patients will be neurosyphilis. Anyway, that is primary what do you call primary bacterial encephalitis. We'll get to that as well, but the more common type is secondary, wherein the patient generally has meningitis. Okay, bacterial meningitis, which is, as I told you, as it gets how should I put it, more complicated rather than chronic, it is getting complicated, meaning it is involving more systems. The patient initially has meningitis, and from meningitis it is going into the parenchyma of the brain. Okay, it is going deeper and deeper into the brain, and it is causing infection of the brain. That is the more common type, and generally as it goes deeper it will cause a condition called cerebritis. Okay, inflammation of the parenchyma of your brain and inflammation of the cerebrum itself is called cerebritis. As cerebritis occurs, you will also see progressive formation of abscesses. Okay, pouches filled with fluid, specifically pus. So there is edematous damage, there is inflammation occurring, and there are abscesses being formed inside the brain. That is the progression of bacterial encephalitis. So this will usually occur secondary to meningitis. Okay, the patient is already having meningitis, then later on they develop this, specifically in bacteria. As it progresses, it will cause so results in bacterial cerebritis, where cerebrum is undergoing inflammation, and progressive formation of brain abscesses. Right. So in a patient who has a very advanced form of bacterial encephalitis, you will see significant damage to the brain parenchyma, and literally chunks of your brain parenchyma will be lost, and there'll be abscesses present in that location. Now the spread of what you call these bacteria, how they are coming into contact with the brain, are through three ways. Okay, it can be iatrogenic, wherein the patient is the same way. Let's suppose a doctor is performing a surgery, or they are performing a lumbar puncture, and they are not sterilizing their equipment properly. That is where implantation of the bacteria is occurring. So literally implanting the bacteria inside the brain, that is one way. Or it can be local extension, meaning the patient is having meningitis, and meningitis set is going into deeper layers and leading to your brain, and ultimately causing bacteria encephalitis infection in your brain. Or rarely it can also be because of hematogenous spread. So the patient's what you call patient has a bacterial infection, and that bacterial infection is entering blood. Technically it should stop, it should be stopped by your BBB, but the bacteria is potent enough where it is either damaging the cells of your BBB, or it is able to pass through the BBB. In either cases, from the blood vessels that are reaching your brain, it is entering the space of your cerebrum, and it is entering into your neural tissue, where it is causing inflammatory damage and infection and all of that. Those are three main ways of transmission. All right, so one second. Transmission occurs by it can be iatrogenic, implantation basically, right? Or it can be local extension. Okay, locally it is occurring in the meningitis, then coming into the brain, or it can be an infection in the surrounding areas. It can be a spinal cord infection, it can be a meningitis infection, something. Okay, locally an infection is occurring and it is reaching your brain, or it can be a hematogenous spread. Blood, say, it is coming into the brain. Right, now the pathological changes that you see in the area will be that you will see necrosis. Now let's suppose this is the abscess. Okay, I'm enlarging it a lot obviously, but let's suppose this is an abscess that is occurring in the brain due to bacterial encephalitis. You will see an area of necrosis in this, specifically an area of liquefactive necrosis. All right, so you will see an area of liquefactive necrosis in this vertical abscess. You will see that it is surrounded by a lot of inflammatory cells. So you will see chronic inflammatory cells as well as acute inflammatory cells. Your plasma cells, macrophages, T cells, all of that will come into picture. Okay, I'm just representing all of them with the green dot. Now along with this you will see a lot of pus being formed. So pus comes into picture. All right, pus will be there, there'll be edema, and as there is local damage, blood vessels are getting ruptured and they are getting, obliterated, they are becoming useless. So you will see neovascularization because a certain area, अब यहाँ पर abscess हो रहा बोले तो obviously blood supply has been lost, necrosis हो रहा बोले तो blood supply is lost. That is why area where there is no oxygen is occurring and it is leading to necrotic area or necrosis. Right, in this area there is obviously inflammatory cells, a lot of chronic and acute inflammatory cells. Your body will start establishing new blood vessels there. So you will start seeing a neovascularization occurring in that area, new blood vessels being formed, or at least they'll be vertical attempting to form new blood vessels. You will see edema in that area and you will see thrombosis. Okay, clots will start forming because there is so much damage. There'll obviously be clots, and those clots will have bacteria inside them, so they'll be called septic clots. Okay, so septic thrombi bhi bolte हैं उन लोगों को. These bacteria, they'll invade or they'll stick into that thrombi. Now thrombi itself is like a sticky structure. That thrombi will be a nice attractive area for bacteria to cling on to, and wherever that thrombi is moving around in your body or in your brain itself, any other area in your brain, it will have an vertical nice vehicle to travel around. Wherever the thrombi is going, that bacteria will accompany. So you will see septic thrombosis of the blood vessels, and you will see that this whole structure abscess is covered by a fibrous vertical fibrous layer or fibrous encapsulation along with a zone of gliosis. Okay, gliosis is when your astrocyte, oligodendrocyte, microglial cells, so on and so forth, satellite cells, so pure they are undergoing inflammation, उन लोग उसको gliosis बोलते हैं. Okay, so the characteristic feature of bacterial encephalitis will be that there is abscesses, and that abscess will have liquefactive necrosis. There is neovascularization. There is pus, edema. There is acute and chronic inflammatory cells. Right. There are septic thrombi. You will also see fibrous encapsulation. The whole thing will be encapsulated in a fibrous structure, and you will see zone of gliosis in and around that abscess. Okay, the vertical glial cells, neuroglial cells, they will undergo inflammation. That is called gliosis. So this is what happens in secondary bacterial encephalitis. This is all secondary. Okay, the patient has some other infection and it is coming here. We'll get into primary encephalitis tomorrow. What is happening in tuberculosis and how syphilis causes primary encephalitis. All right. Hope you understand.